in bradycardia, and this is a little bit complicated. And again, hypotensive patient, you need to get the doc involved right away. But, you know, people who are hypotensive because they're bradycardic, it's usually a side effect of their drugs, or they've had a heart attack, or they have their pacemakers failed, something along those lines, and they're sick. So, you know, immediately put them on a monitor O2, get the EKG, chest X-ray, and get your labs drawn. And then you can give fluid boluses. Sometimes that'll help the hypotension associated with bradycardia, sometimes it won't, but as long as there's no CHF, a fluid bolus of 250 cc's or more is not going to hurt. And then apply the external pacer to the patient, but do not turn it on. You can also try atropine to see if that reverses the bradycardia. But a lot of these bradycardias these days are due to calcium channel blockers or beta blockers. And atropine usually won't help, but there's other things that we can do that the physician will work with you on down the line to see if we can turn it around. But ultimately, if they don't respond to anything, the answer is going to be external pacing. So we have to be prepared to do that. So have that on the patient, but you have to get the doc involved as soon as possible in these patients. This is a sick patient. Hypotension equals get the doc and start the IV, put on the monitor, and get the appropriate tests started, and they're in your protocol. Nausea and vomiting, one of the most common things we see in the emergency department. So this, again, the Zofran can be started in triage. If it's not, then we need to get the vomiting stopped. The sooner we get the vomiting stopped and get the rehydration started, the more quickly the patient can have a disposition decision. So we typically use Zofran, and we can give Zofran as an oral agent, an oral dissolving tablet, or IV. We can do that in children as well. Typically, we kind of break it down. If the child's under 2 or 3 years of age, we use 2 milligrams of Zofran. There's no science behind this, by the way. But more than 3 years of age, we use 4 milligrams of Zofran. And that can be ODT or it can be IV, whichever we like to use. Obviously, we like to use it, the oral dissolving tablet, because we don't have to start a line. And most people, that stops their vomiting. So it's a great way to do it. If it doesn't, and the child looks sick, and if this is in a child, you need to start a line and give them 20 per kilo of normal saline. All right. Again, most kids, if they don't look sick, we don't have to do this. This is one of the reasons we like Zofran so much. We can give the Zofran, get the vomiting stop, and start oral rehydration. And the oral rehydration is really what's recommended by the Pediatric Society. They want you to give a child less than 10 kilos 60 to 120 cc's of Pedialyte by doing about 5 cc's every 3 to 5 minutes. So that means a syringe of Pedialyte, little bits at a time. One of the reasons people fail in oral rehydration is we give them too much at a time. You have to give just small amounts at a time, 3 to 5 cc's every few minutes. And you have to do that over a couple hours to rehydrate them. But the GI membrane is a very intelligent membrane in our body and decides what we need to absorb and what we don't. So that's the best way to rehydrate children who are not sick. When children are sick, we've got to put a line in them and do it intravenously. If they're more than 10 kilos, we give them more Pedialyte, 120 to 240. Again, 3 to 5 cc's every 5 cc's every 5 minutes. Yes?
How long after the Zofran can you start the fluid challenge?
I usually say 15 to 20 minutes.
Okay.
And assuming the vomiting stopped. Okay, and of course, if the children look sick, or children or adults look sick, you need to get labs, CBC, BNP, and an Accu-Check. But Zofran has changed our life since it's come out, particularly the ODT form. It's much easier to give this, get the vomiting started, and start oral rehydration. That's our goal, and it's not as invasive. People like it, and also it gives them a clue that they can handle their problem at home, because we can send them home on the same drug that we're able to stop their vomiting and get them rehydrated in the ED. So it's the best way to do this. Ortho injuries. Again, we've changed our protocol so that triage nurse can order x-rays of extremities or a chest x-ray. However, if they're not done and you have an extremity injury, orthopedic injury, you want to ice it, immobilize it, elevate it if appropriate, and get the appropriate x-ray. Okay, remember, again, you have to examine the patient to know what you have to x-ray. People come in and tell you they have a twisted ankle, but when you examine them, it's their foot. People, twist their ankle, it's actually the foot that's injured sometimes. So you have to really examine to see where it's tender. If you're not positive, x-ray both areas that seem to be sore. I'd much rather have both areas x-ray than have the wrong area x-ray. So if somebody twists their ankle and both the ankle and foot is sore, or the forearm and the elbow sore, get both x-rays. Don't worry about that. But if a physician or a mid-level gives you trouble about that, please let me know about that. All right? It's important that we do the right thing and not have to repeat it. We don't want sequential ordering. It slows down everything. And for orthopedic injuries, medicate the patients for pain. And we know all this. Mild pain, Tylenol or ibuprofen. Severe, moderate pain, some Vicodin. Severe pain, start the pain protocol. Remember, when we say pain protocol, we let the doctor know we've done that. Pretty straightforward on ortho injuries. Overdoses, that's our next one. So people can overdose on almost anything. So we want to put the patient on a monitor, O2, get labs, and the labs that you're going to get are acetaminophen and salicylate in case you overdose on those two because they can be really toxic. Get baseline labs, CBC and CMP. Again, we want CMP rather than BMP because we want to know what the liver function test is. And a PT, particularly if there's Tylenol involved because it's hepatotoxic. If it's an overdose and they're over 35, you're worried about a cardiac effect, you want to get an EKG, you want to know if the patient's pregnant, and you want to get a drug screen to see what the patient took, if it's one of the things that we can measure. Remember, many of the things that people overdose on are not in our drug screen and may not show up. One of the classics is GHB that's out there, and a lot of times that won't show up. Also get a BA, because some of these overdose patients will ultimately be evaluated by psych. We all know what Access wants for them to come in. So they'll want acetaminophen level, they want a salicylate level, they want baseline labs, they want to know if the patient's pregnant, they want a BA and drug screen. So get those and prepared as if Access is ultimately going to come see them. Pain protocol. If anybody needs an update on pain protocol, see Gloria. We've been using this for years. This is now, I believe we're more than 10 years into using this protocol. The idea was anybody in severe pain, and severe pain from a pain scale is over 6. We believe the best way to treat pain is to give titrated IV morphine. Why morphine? Morphine is one of the longer lasting of all the drugs. It's not as euphorogenic as Dilaudid and Demerol. It doesn't have the side effects that Demerol does. And it's highly, highly effective. And you can titrate it safely. So we like to titrate morphine, and the patient controls it. The nurse asks the question, the patient controls how much medicine they get. We start in people under 55 at 0.1 per kilo, over 55 at 0.05 per kilo of morphine. Remember, the first dose is also accompanied by Benadryl. And the reason for this is that morphine causes a nonspecific histamine release. And that accounts for almost all the side effects of morphine. So the itching, the pruritus that you see where you give it is from the histamine release. The nausea is from the histamine release. The hypotension is from the histamine release. If you give an antihistamine with it, you don't get those side effects. So the first dose we give with Benadryl to block all those side effects. And we give 0.5 per kilo of Benadryl with it on the first dose only. And then you titrate it. It says every 7 minutes you go back and ask the patient if they need more pain medicine. This is extraordinarily effective and amazingly safe. The thousands of times that it's been used in the emergency department, we have not had to use Narcan, at least to my knowledge, once. It's very effective and keeps the emergency department quiet. If we love pain protocol, it should be used. If you have physicians who are not comfortable with it, let us know about that. This is something that may be an educational issue where physicians have to be convinced that it's absolutely safe. But it allows the nurses to do what they need to do and allows the patient to control their pain. One of the biggest problems with pain is anxiety. When patients know that you care, that you're going to take care of the pain, the anxiety goes away and you don't need as much pain medicine. So you have to tell them, I'm going to take care of your pain. I have more pain medicine than you have pain. We're going to take care of that. That's the easy part. So you have to reassure them and continue to go back to them and see whether they need pain medicine. Palpitations. Pretty straightforward. Get an EKG, put them on a monitor, and get baseline labs. If you're worried if patients more than 35, palpitations could be related to acute coronary syndrome, get a troponin as well. Really, palpitations, you want to see if the patient's an AFib or SVT, patients cut short runs of VTAC. You've got to get them on a monitor as soon as quickly and get an EKG. Get the EKG to the physician immediately and let us see what's going on.